Good morning, and thank you for joining us today. Our case is a 20-year-old female patient known to be asthmatic, complaining of bilateral gradual painless diminution of vision for 1 year. She presented to the glaucoma clinic with a visual acuity of 636 in her right eye and 612 in her left eye. Her IP was in her 20s on prostaglandin analog. A gonioscopy revealed a closed angle in both eyes. Her anterior segment was unremarkable. Her posterior segment revealed bilateral vascular sheathing with a cupping in both eyes. This is a fundus photo revealing the sheathing, which is more prominent in the right eye. Her fluorescein angiography revealed no active leakage. However, there was a optociliary shunt at the disc in her right eye. And her fundus, her visual field revealed bilateral visual field changes in the form of a lower altitudinal defect in the right eye and a lower arcuate scotoma in the left eye. Her laboratory investigation revealed an ESR of 50 in the first hour and elevated CRP. The rest of vasculitic workup revealed to be negative to ANA, ANCA, tuberculin, and skin test. However, her anticardiolipin IgM was positive and anti-beta-2 glycoprotein. So she was diagnosed by the rheumatologist as antiphospholipid syndrome, primary antiphospholipid syndrome. The patient had no active uveitis or vasculitis, no history of systemic thromboembolic manifestations. Her MRI, MRVs, and MRA was normal, so she was prescribed aspirin and hydroxychloroquine. So we are dealing with a young patient with antiphospholipid syndrome, her IOP reaching 30 on 3 anti-glaucoma medication with cupping and visual field changes. So the decision was to undergo left trabeculectomy under general anesthesia. The operation was straightforward. However, on the post-operative day, she developed a shallow antechamber. She underwent pressure bandage. The AC was formed for a couple of days, but she was shallow again. And so on the second day post-operative, she underwent AC reformation by Helon under general anesthesia. And unfortunately, on that night, she developed acute pain, acute diminution of vision, and her IOP was in her 40s. And the fundus exam revealed this cherry rat spot with an artery occlusion. Her OCT angiography revealed the PAM, paracentral acute middle maculopathy, the hyperreflectivity in the inner retinal layers, and a flow deficit. So she was put on anti-glaucoma, received pulse steroid for 3 days, subcutaneous heparin, and then switched on Marivan, and then she was tapered on the oral steroid, which was then discontinued by the immunologist. So what was the cause of this artery occlusion? And it's very important so we can save the other eye and actually save the patient's life. Was it a thrombus secondary to antiphospholipid? The patient stopped her aspirin 1 day preoperative and did not resume it after the surgery. However, on reviewing the literature, it's very rare and it's not even reported that a central retinal artery occlusion occurred in isolation in primary antiphospholipid syndrome. It's usually in combination with a vein occlusion or in the presence of systemic lupus. Was it the elevated intraocular pressure following AC formation by viscoelastic? Well, we know that glaucoma is associated with a vein occlusion. However, we know that the flow in the central retinal artery and the perfusion pressure depends on the difference between the mean blood pressure and the intraocular pressure. So in patients with systemic chronic ischemia, when the blood pressure is reduced and in the presence of an elevated intraocular pressure, this leads to a reduction in the perfusion pressure, as well as any elevation in the intraorbital pressure, but this happens usually with local anesthesia, and the patient had underwent general anesthesia. Nocturnal arterial hypotension is a normal physiologic phenomenon which is exaggerated in patients with chronic ischemia, and therefore at night time the arterial blood pressure is further reduced, and this leads to a very low perfusion pressure in these patients. Or was it all three? Well, we postulate that this patient had an increased sensitivity to any change in the perfusion pressure. Her latest follow-up in November revealed the visual acuity of 360 in her left eye. Her intraocular pressure was 16 in her right eye on full anti-glaucoma and 10 in the left eye with no treatment. And her cup disc ratio is stable. And this is her last visual field in her right eye. And in the presence of the optociliary shunt, we can detect that this field defect is maybe due to an ischemic insult, not the glaucoma. So my take-home message is glaucoma can be associated with artery occlusion, not just vein occlusion. Careful management of eyes with chronic ischemia, as well as her systemic illness, is very important. And it's important to understand the etiology of the accident to prevent any additional complications. Thank you, and I'd like to thank Dr. Riham Sami, Dr. Ayman, and the Department 12 Red.